So I changed the title of this. I don't know if it's easy or difficult. I'm just the guy who takes the pictures. What do I know? Ask the guys who do it. I don't know if it's good. If it's an 8-minute presentation, I suspect it is easy to do this thing. I was just going to present a case of a Barlow mitral valve and mitral clip. And this was a little unusual in the sense Barlow's usually goes with a big annulus, and this was not a big annulus, so I thought this might be of some interest. So this is an 86-year-old lady, and for all her age, she's very active, but she's been having shortness of breath for about a year, and that's been steadily getting worse. She was seen for surgery because she was known to have mitral valve prolapse, and she was deemed to be extreme risk for surgery, mainly because of her advanced age, and she was very tiny, small lady, 60 kilograms, and body surface area of about 1.47 something, and so she was a very tiny lady, but doing all the things that she was doing at 86 and very active. She also had marked pulmonary hypertension at rest, and therefore it was decided that she would be a candidate for mitral clip. So this is a transesophageal echo, 4-chamber on the top, showing a thickened mitral leaflet. I don't know where the pointers are. I think they are. Bileaflet prolapse, mitral regurgitation, and then the 30-degree view at the bottom just showing the anatomy. There's the intercommissural view, again showing thickened mitral leaflets, bileaflet prolapse, severe mitral regurgitation with a complex jet, and the 90-degree view at the bottom just confirming the anatomy. And this is our standard imaging that we do for all the patients that we do transesophageal echo for mitral valve disease. And the long axis view nicely showing the Barlow anatomy. PISA, for what it's worth, confirming that it's indeed severe mitral regurgitation. 3D TEE, this is real-time 3D TEE, showing both leaflets are thickened, both prolapsing, posterior more than the anterior. Almost the entire leaflet of the posterior leaflet is prolapsing, and most of the A1, A2, A3 is also prolapsing. You can see on the still pictures the bulky leaflets, which are the hallmark of a Barlow's leaflet. And in these still pictures, you actually see a lateral regurgitant anatomic orifice right here from the atrial perspective and from the ventricular perspective right here. Very nicely seen where you might see a jet. And these pictures here are confirmed from the ventricular side, anatomic regurgitant orifice here, thick and prolapsing leaflets from the atrial perspective. Real-time volume color Doppler showing a jet, and it's an interesting jet. If you see, there are two jets. The first jet is actually this red, almost uniform red jet that originates laterally, and then there is very aliased jet that comes lateral and central. There are really two jets in here, and this actually is brought out nicely when you do a still picture. So this is your initial lateral jet from the atrial perspective, corresponding with this flow convergence on the very lateral aspect of the leaflet coaptation, and then after the early systole, somewhere in mid-systole, you see this very aliased jet, which is your central jet, again confirmed by the location of the PISA here, which is both central and lateral. And this is a good one by which you can plan where you want to land a clip. This is not an exclusive lateral jet. There is a very large central element to it, and like was previously pointed out, it is a good approach sometimes, even in Barlow's leaflet, to go centrally and not necessarily go after this jet. You might actually alter this jet if you use this. And what is comforting here is that color Doppler actually confirms your suspicion that going central may not be a bad idea in this. And note also how small this valve is, a Barlow's valve. The annulus is extremely small, so that is a challenge. Here is the first clip from the atrial aspect. The clip is where the aliased jet is from the atrial aspect, so this was considered to be a good location. It does dive a little medially when they enter the ventricle. So here is 2D on the top with the leaflets now grasped in the 2D, and on 3D without color, you can see both leaflets now grasped centrally with the dual orifice, almost equal orifice, slightly bigger on the lateral side. Color Doppler showing residual jet on the lateral side, so the jet almost has moved laterally. You still see this very significant flow convergence on the ventricular side laterally. So this is before tightening the clip, and now you're actually tighten the clip here on 2D. You can see the MR has virtually disappeared with a small jet laterally. But look at her mean gradient with a small annulus. With a single clip, the mean gradient is up to 3.8. This is now, the clip is being tightened. You can see actually dynamically the MR has gotten much better. There's a small uniform red jet, and the very substantial pizza that you saw on the ventricular side has almost disappeared. So this is very helpful in which you can have an eyeball qualitative assessment or a semi-quantitative, because you're actually looking at the disappearance of the flow convergence on the ventricular slide. You can see as you tighten the clip, the MR is getting substantially smaller and the pizza has virtually disappeared on the ventricular side. And this is now a fully deployed clip, still attached to the delivery system, but fully tightened clip. And now the clip is in final position. The clip is released. This is 2D here showing residual MR. And this is a game that we play in the cath lab. I make this up on my fly. I tell my interventionists whatever they want to hear. If this is mild, this is no science at all. It's absolutely. And this evening, I'll show you. I'll show you how to bring a little bit of science to this, what is really an art form. I'm not complaining. I'm just saying this 1 + 2 + is such a bogus thing. You can make this up. That plus is there for exactly the same reason. Nobody knows if that plus is close to the 2 or is it close to 3. That plus puts it somewhere between 2 and 3. So it all depends on the day you want to have. I call this mild MR, and don't ask me why. And here is intercommissural view, dual orifice. There is MR. I wouldn't like to have this MR, but to make our interventionists happy, I call this mild MR. So
that's a true partnership.
Yes. So if you see on 3D, it's a uniform red color. That usually helps me. If it's an aliased flow, I do know it is a substantial MR. That's a uniform low velocity flow. I'm a little comforted, and no pizza here. If you look at this lateral jet that comes off on the atrial side, but on the still picture, I begin to see this pizza right here on the side of the clip right here. So I had a suspicion that this may be more substantial than I think it is going to be. It may be more than mild MR. And you actually see a regurgitant orifice laterally on the atrial side after the first clip, and you see that orifice on the ventricular side right here. So the suspicion here was, although it looks mild now, this MR might actually progress. But the mean gradient was 3.8, and we decided it's a small annulus. Another clip would only increase that mean gradient. We decided that we would not mess around with this any further. And we decided we'll leave it at that, and the mean gradient actually improved finally to 2.3. So that was good. She went home. She felt better for a while, but she continued to be short of breath, and she didn't feel good about that. So 6 months later, this is a transthoracic echo. 4-chambered view, apical long axis view shows a jet here originating laterally, going medially. In the apical long axis view, you see this jet, and you also see this in parasternal long axis view. This doesn't look like mild MR to me now. And for what it's worth, and we don't do this as a routine post-clip, PISA measurements are very unreliable, but in this case it helps because it does confirm that this is significant mitral regurgitation, EROA of somewhere between 0.3 and 0.4, and a vena contracta of almost 8 millimeters. The mean gradient, it was not worse. It was 2.8, so it was what she was left with. So we decided that this lady deserves a second clip, so she went and had a second clip. This is 2D TE at baseline. You see the flow convergence laterally to the first clip in the 60 degrees and the 90-degree view. This is the 3D TEE showing a large orifice on the lateral side, and color Doppler showing a very significant lateral jet. And always, this is very helpful. This is one thing that I've learned doing color Doppler by 3D TE real time, is to look at this side and not get excited by this one, because this tells you what is going on this side. And you can see a very substantial pizza. This pizza has gotten bigger than what it was post-immediate procedure, right here, lateral to the first clip on the ventricular side. Here is a still picture showing you that flow convergence, and here is that lateral jet on the atrial side. So here's the second clip, lateral to the first clip, almost on the first clip. And I've stopped telling them how they're close to the first clip. TE is very misleading. Fluoroscopy is so much better. I always tell them they're sitting on the first clip, which is not true. It is actually lateral to it. Fluoroscopy has a better resolution than 3D TE for that purpose. But it is in the jet. That is good to see. It is in the jet. The arm angles are good. And so they go into the ventricle, grasp the leaflets. And so this is now grasped on the lateral side. And you can see a substantial change in that lateral jet of the residual mitral regurgitation. This is both clips now in place, fully released. You see a dual orifice because they're almost against each other, this clip. There's almost no gap between these two clips. And now the MR is a small uniform lateral jet that is seen here. No flow convergence on the lateral side, not even a tiny dot in there. And the mean gradient now is 3.8. Small annulus, but this is what she had after the first clip when we only had one clip. So she seems to generate this gradient as soon as you put a clip in there. She went home. 3 months later, she comes for a follow-up. She's feeling much better. She's still a little short of breath, but she's much, much better, feels happier. This is a transthoracic echo. This was earlier in the year. This is fourth chamber now, just showing this jet right here from lateral. This is fourth chamber, and this is the apical long axis view showing this. I'd be very careful about looking at color Doppler post-clip. We tend to overdo this thing. You see how transient that jet is. It doesn't persist throughout systole. And any measurement you make here, vena contracta or whatever, is so misleading because that's one frame in systole. And that's why the best way to assess these jets, I feel, post-clip is regurgitant volume, because that takes care of the entirety of the cardiac cycle. This is non-holosystolic MR. You see the spectral Doppler? And for all of us who do quantitative MR, non-holosystolic MR, PISA, and vena contracta are extremely unreliable in classifying the MR. And look at the pulmonary vein flow. It's pretty substantial and does not show significant mitral regurgitation. There's no flow reversal. Admittedly, this is only one vein, but this is very comforting because this is non-holosystolic. Generally, they tend to be mild or mild to moderate MR. And this is our mean gradient, 2.7. So she was 3.8 immediate post-second clip, but now it has come down to 2.7. She's doing well, and this evening during my presentation, I'll show you how we measure immediate post-clip and during follow-up regurgitant volume by using volume color Doppler, completely automated by echo, so that adds to every other assessment we make about residual mitral regurgitation. So case of Barlow mitral clipping. Thank you.
So this evening you'll be able to see Dr. Vannan and several of us at the MitraClip Dinner Symposium on the 38th floor here at the Grand Hyatt. So it's got a great view, and so please come. I think for the Barlow's valves, I just want to ask you, the challenging aspect of them is the concern of SLDA because of how mobile the anterior and posterior leaflets are and whether or not the leaflets will stay after the anchoring. Do you have a different threshold for putting in second clips or additional clips besides one clip for these Barlow's valves compared to regular valves?
If the annulus is big, the rule of thumb is 2 clips for Barlow's, at least 2 clips. But this annulus was so small, and the mean gradient went up to 3.8. Yeah. We were very hesitant to put a second clip in there.
So if it hadn't been for that gradient, you would have put in a second
Absolutely.
clip?
Yeah. Absolutely.
Yeah. Myra?
Was that a cleft between D1 and D2, or do you believe in clefts? There's a lot of debate. I mean, do they really exist? In this case, there was a little space and there was a jet from there, or is this just part of the anatomy?
I do believe in clefts, but unless I see color flow through them, I don't call them clefts because it's physiologically irrelevant to. Mike will talk, knows about these things. They close during systole, most of these things that we call clefts. Unless I see flow through them, those are very rare. I go to this OR in mitral valve, and I always keep telling our surgeon there is cleft, and he goes, it doesn't matter because those actually close.
It's more like a fold than a cleft.
Yeah, it's a tough one, Myra. I don't know the answer to that. But the flow.
If you don't have clefts, you can't open it up.
Yeah, that's right.